Hello everyone, welcome back to Hot Seats Season 3. I'm Omid Moghaddas joining you from Tehran, and as I always say, I'm so happy and honored to have this chance, especially during the pandemic situation over the world, to share this educational platform with you along my dear friends and master clinicians from around the globe that are kind and generous enough to share their knowledge and their expertise with all of us and help all of us to gain better understanding in treating our patients. And today, one of our dear friends, and I really have to say, this guy is genius. He is not only very skilled and a super talented clinician, but also he puts so much effort in education, in providing educational content through his Instagram page, which I truly recommend you all. If you haven't checked it now or yet, you have to check this account to learn a lot of great things from this gentleman. My dear friend, Dr. Jorge Alania is joining me. Hello, Jorge, and welcome to Hot Seat.
Hi, Omid. Thanks for the invitation. And I really appreciate this invitation of you to stay here in your space and to give me the opportunity to share what are we doing here. And I live in Lima, Peru, very far from you in South America.
Yeah. But I promise you that I should visit there very soon. And I know that you are living in a very beautiful area. So lucky you, and hopefully meet you soon also in person. Today, the topic that Jorge gonna talk about for us is actually one of the topics that we really didn't have that much time talking about it on Hot Seat. So I'm so happy for today's session. And it's about Gummy Smile treatment protocols. As you all know, Gummy Smile is one of the most demanded treatments from our patient side, and different scenarios can happen dealing with these patients, you know, with aesthetic crown lengthening, with non-surgical therapies like the Botox, with, you know, or maxillofacial surgeries that sometimes we need to take into considerations, and lip repositioning, and so many things that we need to think about. We need to think about the etiologic factors and how we can bring the best outcome for our patients with the demand of treatment of Gummy Smile. And today, Jorge going to talk about and show us beautiful case managements, and we will go in depth of the etiologic factors and the treatment protocols of the patients seeking for this type of treatments. And for sure, as our routine in Hot Seat, we will have a great discussion on the topic. But before we start, I would like to have a very short CV of Dr. Jorge Alenia for all of you. And then we will go through the presentation and we'll enjoy every second of his amazing work. Dr. Jorge Alania is expert in periodontics from University of Peruana Cayetano Heredia, also residency in periodontics. He had an implant dentistry from the same university, UPCH, master in stomatology with mention in periodontics from UPCH, guest professor from universities of Mexico, Honduras, Colombia, Bolivia, and Peru, and member of International Team of Implantology, ITI, member of the Association of Periodontics and Osseointegration, and also member of, if I pronounce it right, Ibero-Pan-American Federation of Periodontics.
Yes.
So with that said, my friend, the platform is all yours. And me personally, I think as all the audience, we are ready from head to toe to hear your beautiful presentation. You can start sharing your screen.
Thanks, Omid. Thanks for this great presentation. And it's a lot for me. It means a lot for me. I will share my screen. So now we can show all this for you. So we are here to talk about gingival, about Gummy Smile treatment. Yeah.
Yeah.
So gingival excess has been recognized by the AAP, American Academy of Periodontology, as a gingival deformity around teeth. Several conditions may result in the excessive display of gingiva, like you said, including pseudopockets caused by gingivitis, drug-induced gingival enlargement, and altered passive eruption of teeth that we will see some cases about this. These clinical presentations may lead patients to seek treatment to address aesthetic and or functional concerns, because we cannot separate perio goals from restorative goals. We need to understand that we need to learn how to manage both, yeah? And we cannot separate them each other. So excessive gingival display may also result from an altered passive eruption of the maxillary dentition, also a highlight line and a hypermobile upper lip, or vertical maxillary excess. And the management of excessive gingival display is dictated by etiology, like you mentioned before. So I want to show you today a smile design from a surgical approach, an approach from a periodontist with limits, yeah, because I'm periodontist and I do not perform orthodontic surgery, for example. So we are trying to show what would you do. And this picture that is taken from Google, if the design really matters, the design really matters. And nowadays, patients, I feel since 2000 until 2021 today, patients are looking for aesthetics more and more and more every day. So today or nowadays, nowadays we have several digital tools to achieve better results and more precision. This case that I solved in Colombia, I use Photoshop Smile Design, and this is very fun. Yeah, and now it's easy for me. And what I'm trying to show with this video is that we need to learn how to use these tools as an advantage for us, for periodontists, okay? And also, not for prosthodontists, I think every dentist have to learn how to manage this smile design, yeah? Also orthodontists, okay? To achieve a proper results, talking about how to manage a smile, okay? So in aesthetical parameters, ideally when a patient smiles, is supposed to expose 1 to 2 millimeters from the upper aesthetic front. But in these aesthetic parameters, the main or the principal parameter, I think, is health. If you don't have health, you don't have nothing. You don't have aesthetics. So in this case, the patient reports that he has been this is my design 1 month before, and we can see here that we don't have any parameters of aesthetic. We have here inflammations, certainly in this part, this level, a level of the papilla, and also we don't have harmony between tooth, yeah, with the contralateral side, and we don't have the very good scalloping margin, gingival margins. So this is a very, very sad situation for me. The patient reports that 1 month ago, I got this smile design, and this is frustrating for me. And we have to learn that health is important. As a periodontist, I always emphasize, give the importance to the health situation, and we need to check the colors, the surface consistency, and we need to remember that we need attached gingiva keratinized gingiva with all the characteristics that they have, also the mucosa, okay? But when a patient presents this inflammation, this result on aesthetics is on health, but also on aesthetics, okay? And also we need to understand that a smile design could be with additive or subtractive. We can, talking about teeth or gums or gingiva, I can, in this situation, add gingiva by gingival grafts, or in other situations, we can perform gingivoplasty, gingivectomy to be a subtractive way. And like I said before, we cannot separate the pink from the white and the perio from prosto. And we need the balance. Yeah, we have nowadays pink aesthetic score, white aesthetic score, yes, and well, pink aesthetic score was created by for implants, for anterior implants, single implants. But then we apply this to anterior maxilla, and we show that the score that the top is 14 anterior teeth, the maxilla has 12 to 14. So it's a good score to evaluate aesthetic at level of gingiva. And another point is the interdental space, so the papilla. And the level at interdental space, we have two kinds of patients with high scalloping or low scalloping. The idea is avoid the black triangles. And to avoid black triangles, we have to learn how much or how is the mean of the papilla at the anterior region or the aesthetic region. And Chu in 2009 showed that it was like 40 to 46%, and with a mean scalloping of 4 and 4.5 millimeters of papilla at the aesthetic region. For avoid these black triangles, also we need to understand that we have to respect this distance from the interproximal crest and at the contact point that we learned from Tarnow at 1992. Another point is the point of the zenith, the gingival zenith, that Matos and Chu also show us that for example, the zenith of the central incisor is 1.1 millimeters to distal, and the lateral 0.4, and canine is at the same level of the bisectrice. These all parameters are about gingival, yes? Also, the lateral incisor is 1 millimeter approximately coronal to the gingival zenith of canine and central incisor. Also, we have the supracrestal distance that we called before biologic width, and there is a magic number until now, but we use 3 and 3.5 more or less. The point of the cement enamel injection to the alveolar crest. Okay, this is our concepts that we know a lot of. We have a lot of information about this. And the information newer is that this supracrestal distance is different in the anterior teeth, premolar or molar teeth. So after this gingival evaluation, we have also dental evaluation that I will not focus on this, but we need to remember that we cannot apply one parameter for all the patients. So I need to present this slide because the radio of teeth are important, so I can have a radio with a 0.8 or 0.75 or 0.6 and all these radios could be for every patient. So I need to establish how my patient needs or what my patient needs. So also in this dental evaluation, we evaluate color, form, angles, triangles, yes? But I want to show that every part is important. The intra-arch evaluation, the vein proportion, that is not also the only proportion that we have. We have now a recurring aesthetic dental proportion, also of shoe, okay? That is another way to evaluate proportion. The intra-arch evaluation to the location of dental incisor at rest and in smile, the overbite, overjet, the axial inclination, the dimension of vertical occlusion, phonetics, anterior guidance, yes? Also, we have to remember that in an ideal smile, I need help. That is what I'm talking about in these slides. Using traditional clinical examination and treatment planning techniques, patients were generally reclined while the general dentist performed the intraoral assessment. This limited the dentist's visual reference frame and forced him or her to focus on specific intraoral problems. But an ideal smile needs to be farther, or the evaluation needs to be farther. I need to evaluate health, function, but also beauty. And when we talk about beauty, we need to talk about another evaluation, like dentofacial evaluation, like facial evaluation, because the times and the patient have changed. So I need to focus not only on gingiva, not only on teeth. I need to focus also in facial and dentofacial evaluation. So in dentofacial evaluation, I need to evaluate, or I need to remember that I have a static and then dynamic analysis, okay? And in this dentofacial evaluation, for example, incisal plane is parallel to the lower lip, and this is parallel to contact point. I need to create or recreate symmetrical buccal corridors, to remember also the lip corners raised to the same height. In this ideal smile, when we are talking about smile design, to truly appreciate a magnificent work of art, you must view it in an optimal environment. In such an environment, frame, context, line, and color are complementary, not only from close up, but also from a distance. Each element contributes to and enhance the overall impact of the image, creating a result that seems to fit together perfectly. Today's dentistry is also an art in which the elements of color, balance, proportion, composition, and harmony blend to create a picture of health and beauty. Yes, in this age of high-tech appearance and image enhancement, it is not surprising to imagine that the smile impact on an individual's success, prestige, and position, both professional and personally. So when we talk about dentofacial and facial analysis or evaluation, when a vertical line is drawn to the nose onto the midline of the maxillary teeth, yes, I place one slide, it is the same, similar, or parallel. Also, we have to talk about the interpupillary line. and the incisal edges of the central incisor are parallel. And we have to learn how to transpolate this bipupillar line to a plaster model, for example, because the lab is not seeing the patient, and we need to learn how to transport this information. Also, we have to talk about facial trees. They are in a balance. They have proportion, these facial tears. The amount of visible tooth contour is evident, but decrease from the anterior to posterior with similar proportions on right or left sides. A greater amount of maxillary than mandibular teeth are apparent. Yes, this is what I'm talking about. We show more maxillary teeth than mandibular teeth. And also, patients showed normally displays 8 to 10 maxillary teeth. So I think that the aesthetic region is broader nowadays. It's not only to canine, it's broader because patients are displaying 8 to 10 teeth. Also, the upper lips covers the majority of the soft tissues bouncing. Only the gingival papillas are displaying. There is an adequate amount of attached tissue, yeah, because we need attached gingiva to create also aesthetic parameters, that it appears to fit into the architecture of the face and smile. The color of teeth, they have to be appropriate, and also remember that gingival tissue has a knife-edge margins, no sign of inflammation, no stains or accumulations. There are no other problems that make the tissue appear red, or teeth yellow or brown that could be a result in a visual distraction for the smile. Okay, so each individual element complements the whole picture. There are no visual defects or distraction that catch the viewer eyes, so patients should be routinely assessed with these elements in mind. And talking about Gummy Smile, we know that an exposure than 3 millimeters of gingiva could be categorized by Gummy Smile. That is more prevalent in women than young people have it in a 10% between 20 to 30 years old. The excessive, but why Gummy Smile results unattractive? And excessive gingival tissue of the maxillary arc is unattractive because of the shifting proportion of the vermilion border of the lip and gingival tissue in relation to the white colored teeth. As more of the gingival tissue is exposed, the ratio of red tissue to the tooth increase because lip and gingival tissue are displaying more, drawing the eye to the red tissue instead of the teeth. So that's the reason why gingival display in excess is unattractive. And Gummy Smile etiology, it could be by altered passive eruption, vertical maxillary excess, upper lip and hypermobility, short upper lip, gingival excess, or a combination of factors. Altered passive eruption, we have this classification of causes that we have a lot of time, but in this altered passive eruption, the alveolar crest is very proximally or at the same level of the cement enamel junction. The difference between 1 and type B is the amount of keratinized tissue, and this determines what kind of treatment I could perform. So if I have a lot of or a large amount of keratinized tissue, I could use gingivectomy with any problem. But if we have a limited amount of keratinized tissue, I have to see other ways to put or to get the crow lengthening. And the other is the maxillary excess, the vertical maxillary excess. And we know we have to remember that we have to take the palatal plane and the caesal edge. And if this is more than 31 millimeters in a cephalometric erect, we could call it vertical maxillary excess. And we have a classification taken from Garber and Salama, degree 1, degree 2, and degree 3. And in relation to this degree, we can have some treatments, like in grade 1, we have orthodontic intrusion only, orthodontics and periodontics, or periodontics and restorative therapy. Also in degree 2, periodontics and restorative therapy or orthodontic surgery. And with is a grade degree 3, 8 millimeters or more, you have to call to the maxillofacial surgeon. So we will talk about only degree 1 or 2, knowing our limits. If we have hypermobility upper lip, how to diagnose that? So, a study from UCLA reveals that if patient at rest, and when we compare with the smile, and we have a change of the distance from the subnasal point to the inferior border of the upper lip, if it have changed more than 8 millimeters, we have a hypermobile upper lip. So in this patient, for example, we have 10 millimeters of change. And also short upper lip is another difficult situation. For example, in a patient with you want to perform lip repositioning, I think that short upper lip is a contraindication. Also gingival excess, that we can solve this with gingivectomy, and in the new classification we are here, and excessive gingival display into mucogingival deformities. I want to put this slide because always, almost always, dentists forgot crow rod proportion, and they want to make crow lengthening, and the proportion is very, 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 it's not a good proportion. Yeah. So to talk about planning, about treatment planning, and nowadays we have tools like smile design tools like Photoshop Smile, or from Edward McLaren, or digital smile design from Coachman. So I need to remember that we need EFP, that is incisal edge position, that determines aesthetic, phonetics, and occlusion. We can use in some patients modified Lucia jig in order not also to determine vertical occlusion, also to determine the incisal border, but also determine the new gingival margin and the new aesthetic parameters about talking about gingival margin. I like this rule 42.2 of Edward McLaren, that it says that the patient show 4 millimeters maximum the maxillary central incisor at rest to is that 2 millimeters maximum gingival display in a smile, and the point to separate the mandibular arc from maxillary arc. And this new two is that the patient show lower incisor 2 millimeters or less in a smile. Okay, and when we have these patients about a Gummy Smile, I performed this smile design. I got a WhatsApp and perform a mock-up, and then I could the gums, or I performed the gingivoplasty with the mock-up. This is the old way that I did it this case. And then I performed the lip reposition. And in lip reposition, I think that we have some key points. The first is that we need how much mucosa we have to remove. And I think that we have to remove the double gingival display in a smile. For example, if a patient display 4 millimeters in a smile, I remove 8. If a patient shows 6, I remove 12. And the first incision always needs to be at the mucogingival junction, almost at the mucogingival junction. Why almost? Because we need to leave some attached gingiva, because you have to remember that one principle of suture is suture to the mobile, to the fixed point. So the mucosa at the apical level is mobile. So I have to put this new insertion of muscles more coronal, and I have to put them in a fixed point. And that fixed point is the attached gingiva that I learned. Also, we have to make the incision with a bevel, with external bevel, in order to leave this connective tissue to be posed for have a better adaptation when we when we advance the flap. And this is this case with how I solve. This is 6 months follow-up, and this is a profile view. Okay, and patient is ready for the restorative part that I don't do that because I'm periodontist. And in this case, this patient was a dentist and doesn't want to change the form of her teeth, and she doesn't want to be submitted to a crown lengthening procedure, only lip reposition. And we do the same. We evaluate the patient and the static and dynamic. I evaluate the dynamic smile, and I remove the double of mucosa that she displays in her smile. So in this case, she shows like 6, 7. So I remove 14 millimeters mucosa, since the mucogingival junction for apical direction. And I don't perform myotomy. I feel that is very cruent. I use PDO sutures internal PDO sutures in order to immobilize the muscles the much time that I can. And also, I want that you note that when we perform a lip repositioning, the thickness of the upper lip become larger. because we have like an aversion when we perform this kind of surgery. So if you have a patient with a thin lip, it's okay. But if you have a patient with a very, very thick lip, it would be with anesthetic results. This case will finish very, very successful. There's a case that I like or I enjoyed so much. And to prove this in a video, this is the initial smile. So she displayed a lot of gingiva, and this is 14 days after surgery and 28 days after surgery when we are trying to make loud patients, and she can loud more and she doesn't more. Okay. And literature reports that it has almost 100% of recidiva, okay? And but with PDO sutures that have a lower rate resorption rate, I'm getting very, very, very successful results, because the rate of resorption of this kind of suture is like 6 to 8 months. So I need to evaluate these internal sutures or this kind of sutures, and maybe make a study or something like that to prove that these internal sutures could be or could give us better results. I use 5 internal sutures, one here, the other here, yes, at the more distal levels, and the other is here at the central, and in this order, because first I want to evaluate the lip corners that are that they have to be at the same level, and then I put the central suture because I want to form this arc of the lip, and I use another here and here, equidistance to these 3 points. And also this internal suture, I start at the mobile line in the more apical part of the incision, and remember that it's not vertical, even is going like an arc. So I have to take the point with a 15 or 18 millimeters needle to cut the most part of muscle that I can. So I have to lift there, have to advance the flap and put it at the gingival attachment. And this point is a horizontal mattress. And I perform 5 horizontal mattresses here. Okay, so the key point is evaluate aesthetic and dynamic smile to determine how much mucosa you need to remove. Fear incision always at mucogingival junction, because if you perform this more coronal, you will, maybe if you have a recidiva, you will have an aesthetic result with a scar. Yeah. So, yeah, and the other key point is I use PDO sutures, polydioxanone sutures. Okay, I don't perform myotomy. This case is here 3 months after, and here also 3 months after. Okay, and this is pre and 1 month after. this case has vertical excess, vertical maxillary excess. This is a case that we solved with Patricia Freitas and Ricardo Kern, and we use PMMA, polymetal metal acrylate microspheres. So we determined that, and we plan in the case the crown lengthening, and we note that in the CBCT that cement-enamel junction was very, very near to the gingival margin, so we can perform only 1 millimeter, 0.5 of gingivectomy. And also we have to make the osteotomy, and we have to raise the flap very, very apical to put the PMMA. Okay. This is the planification. This is the CBCT, VCT. And we have, so we note some exostosis at the CBCT, and also we check, we control the thickness of the gingiva, and we use this compass to be more precise at the gingivectomy. So we raise the flap, and we can appreciate here that we have a very, very big depression, a very, very big concavity. So in this kind of patients, so where we have vertical maxillary excess in degree 1 or 2, we can use PMMA to solve this case. Yes, and this is improper supracrestal distance. This is the exostosis that I note in CBCT, and we perform osteoplasty, and look how it changed, because the lip goes up the exostosis, so it collaborates to have more gingival display, so we have to perform osteoplasty. Here we perform the osteotomy also, and we have proper supracrestal distance. Now we prepare the PMMA. This is the form, and we have to be placed at the gingival, at the smile of the patient, at the same level as the smile of the patient. This patient, her smile goes between premolar to premolar, so we decide to put the PMMA until this level, and we fix it. And this is a profile view on how we are filling this concavity for avoid that the upper lip goes there. And this is the suture, and this is the patient 2 months later. These cases are to avoid orthodontic surgery. It's not to solve all the gingival display. It could be better, but it's not to solve or it's not to replace the orthodontic surgery. Okay, this is a profile view. It looks better, and I think it's with aesthetic results also. The indication is vertical maxillary excess 1 or 2, not 3. 3 is for orthodontic surgery. Also, when we have hypermobility of the smile muscles, and an important point is that you have to note that presence of concavity, yes, at this level, okay? And there is a marked subnasal depression. So this is a case where we have to indicate PMMA or biovolume technique, yes? And these techniques that are more simple, this is talking about crown lengthening, aesthetic crown lengthening. Okay, and we perform an smile design. We decide how much gingiva we have to take off, or how much teeth we have to add. And we perform the gingivoplasty, and we erase the flap. And key point here is not to raise the flap beyond the mucogingival line, because we have to put the flap at the same level. And if you raise the flap beyond the mucogingival junction, you will become this flap a mobile flap, and the flap could be advanced, and you will not put this flap at the same level that you performed the gingivoplasty. So this is a key point that we mentioned. We also, you can note that here is the cemento-enamel junction, and is very, very near. It looks like I didn't do nothing, but remember that we determine how much is the proper proportion or ratio of these two is. I'm talking about, or I want to that clear this, is that not always the cemento-enamel junction is a good benchmark, is a good point of reference. Maybe in some patients, if you perform the gingivectomy until the cemento-enamel junction, the tooth will appear too long. So you need to remember this, or you have to remember this in mind. Okay, and this is the case how we solve, and now it's ready for the restorations. Okay, and also this smile, this is a model patient, and we perform also a digital smile design. We decide how much to gingival remove, and also this surgery occupied the aesthetic region. I don't perform a flap over the canines. I perform osteotomy and osteoplasty, and then we have 7 days after surgery. I will show you a video of how I do that. 7 days and 3 months, and patient is ready for some restoration, little restoration here, okay, in order to enhance this. Another case is this case, so about crow lengthening, and I want to show you how do we use this compasino, like Ricardo said, called, that is very, very precise to put the incision, how to put the start incision. And this is about thickness control, because when I have to do a perpendicular incision or internal bevel incision, and this depends of what quantity of thickness of soft tissue I have. If I have more than 2 millimeters of soft tissue, for example, in an altered passive eruption, where patient almost always have a very thick phenotype, I have to make a bevel incision because we have to reduce the amount or the quantity of the tissue. And if, on the contrary, if I have a very thin phenotype, I cannot do that. So I will always be almost perpendicular. For example, if you use electrosurgical unit, you cannot control the bevel. So in patients with thick phenotype, I think that we have to use a blade. And if in thin phenotype, if you will use more perpendicular, we can use an electrosurgical unit to perform the gingivectomy. So in this case, I want to show how I perform this surgery, with how I use this compass, and how we have the incisal border like a reference, because it did not change. I performed the gingivectomy, and that incisal border is over there always. I perform internal bevel incision, then an intracircular incision, and then we remove this Gracie scalar. Okay, we perform the gingivoplasty or gingivectomy, and this is I have a question for you, Omid, and this is about if you call this gingivectomy or gingivoplasty, because I think that gingivectomy is when you remove farther than cement to enamel junction, because this is for aesthetic reasons. And for me, I call it gingivoplasty, but I don't know what is your opinion about this. And well, we perform this in all teeth, at the canine level, at the premolar also, then the other side, okay? And we erase the flap. This is all the gingivoplasty, the intracircular incision to raise the flap. And for raise the flap, I use a P24G that has a trapezoidal form, and I use to raise the papillas. When I erase all the papillas, I erase the flap. We need to do this carefully in order to don't damage the gingival margin and erase the flap. If you feel some tense in the flap, it's because we need to do the incision again or remerge the incision. Okay, so we raise the flap here with the other part of the P24G that is like a spoon. Okay, and we don't have to go beyond the mucogingival junction. We don't have to go farther. And here we have the flap. This is the flap. And now we can note that this is an altered passive eruption. We have the cement enamel junction very, very near to the alveolar crest. So now we are mark the osteotomy, but first we perform the osteoplasty. We have to reduce the amount of buccal bone in order to facilitate the osteotomy then. So we perform osteoplasty with this number 18 round bore. And then we perform osteotomy. I'm raising the flap, the molar level, because we have exostosis and we have to remodel this bone. And then we have to perform osteotomy. The osteotomy I perform with another board that is only cut at the end of the board. In this way, yes, carefully without touching the root. Yes, and go to the level that we determined before. Okay. Then we have to remove the rest of periodontal ligament because we need, or I don't want that are regrowing. a rebound, a gingival rebound. Yeah, so that's the reason why I perform like scaling and root planning at the level of the root after perform osteotomy. Okay, it's the difference when we are performing a root coverage and we do not touch this part of the root because we want more cells, more periodontal ligament cells. Okay, this is all the osteotomy, and after osteotomy, I polish the root with low rotation burrs. That is this. I polish the root and it's like a casement. I use low rotation here with these burrs, and also to perform or have better results in osteoplasty, to have bevels and scallops for the bone. And I perform then the suture, and I want to show, sorry, that if we don't go beyond the mucogingival junction, you can put the flap at the same level that you perform the gingivectomy. Okay. So now I use vertical matrix sutures for the middle line, and then I perform a sling suture. Yeah. So it's 6 millimeters from the contact point. Here also like 6 or 5 millimeters to the point of the papilla, and there I return more chronal and goes to the palatal side through the contact point. Okay. And it leads that papilla could be in a more chronal position. Okay, and the other sutures I prefer to use sling sutures, starting at palatal side. I start at palatal side without pass through the tissue. I pass the tissue at buccal side and put for getting the papilla around the tooth at the palatal side, and again at the distal level, the buccal distal papilla again, passing to the contact point, and I make the knot at this level. I may make the knot at the palatal side, and here it's the same. So I perform this surgery. All the points are the same, sling sutures. Okay. At this level. So this is the gingivectomy, the flap, the osteotomy, and the osteoplasty. This is after perform osteotomy and osteoplasty. A suture, profile view initial, profile view 7 days. This is the intraoperative view and postoperative view after 7 days. Yes, a smile after 7 days. And this is the patient 1 month later ready to receive the veneers. So this is what I try to show today. I hope you enjoyed it. And if you have any question, my friend.
Absolutely, Jorge. I have to say, I really predicted this. It was beautiful. It was comprehensive. And you really showed in depth the beautiful management of a Gummy Smile patient. So really thank you for that. I actually have many questions, and I think it will help also our audiences to get the better understanding of the steps that you showed in treating of a patient with a Gummy Smile, treatment demand. So, you know, one of the things that I'm really interested to ask you the question about is, you probably mentioned it, but I just wanted to make it more highlighted in the presentation about the importance of the lip length in the cases that you want to decide to do either lip repositioning or using the biovolume with the PMMA. So imagine your case have a short lip length. In those cases, do you also recommend doing lip repositioning, or is contraindicated if the lip length is short?
No, if the lip length is short, less than 24 millimeters, I think is the reference, is contraindicated using I think, for example, this patient here, we have a short lip.
Yeah.
So this case is for the orthodontic surgery. It's not for periodontist.
And also, what about if the patient has hypermobility, but the lip length is short? What about the PMMA or the biovolume? Do you also, is it also recommendable or not?
Not, because the labial incompetence will not change, and the patient will have to force the lower lip to close their lip. So it's contraindicated. I think that short lip is a very difficult situation.
And you know, one of the other things that it really attracts my attention was using the biovolume with the PMMA that you showed. I want to know, in the cases that you showed, did you make that PMMA chair side, or did you?
Chair side.
Yeah, it was chair side, because some people can make it through the CBCT and make it as a guide and scan it
with a digital flow.
Yeah. So, but you did chair side. So I want to know, what is your criteria for the thickness of that PMMA? And, you know, you talked about how to choose the distance from here to here, depending on the showing of the Gummy Smile. But what about thickness? How thick should that be?
We have to evaluate the patient in a profile view. And the result harmonic, and we cannot change the angle of the nasolabial angle. It cannot be too agudo.
Yeah. So can we say that we should only feel the concavities and make it even? Can it be as a guide? Yeah.
Yes, it's like it has to be a straight with a fascial bone.
Yeah, it should be flush with the bone.
Yes.
Okay, that's a good point.
All that.
Yeah, great point. And you know, one more thing that it really attracts also my attention, and I think that's
right.
Yeah, exactly. And what about the apical chronal distance of it? How do you measure it?
the apical coronal distance it has to be until the subnasal point. Yeah, when we raise the flap, it's very, very apical.
Yeah.
Almost until the nasal orificial nasal that we have over there. And here we have to put it in, I think this maybe 5 millimeters from the alveolar crest.
Yeah.
Okay.
That's a rule. That 5 millimeter is a rule. Is a general rule for everybody.
I think yes, because it you remember when a patient smile, and if the patient smile more than 5 millimeters, they will show more. Yeah, and we will resolve anesthetics. So if you put it more coronal, we will show I don't know, with a groove in the gingiva. So we have to be more apical.
Yeah, great point. And you know, speaking of lip repositioning, you talked about the importance of the bevel. You talked about the importance of the suturing, where we should start and how to end it, and the amount of part of the lip that should be double of the Gummy Smile display to make sure that everything's going to be perfect at the end. Now, my question is regarding the thickness of the mucosa that we want to harvest, because we have different recommendations, but generally, as you said, and as I remember, and also I took in my practice, usually people recommend to only remove the thickness of the mucosa, you know, comparable to the bevel of your blade, and not go any more deeper. So do you have this concept?
Yes. We have to go over the aponeurosis of the muscles. Because if you go farther, it's more cruent. You can make some damage, some innervation if you go in a split thickness. If you don't go superficial, you can damage the nerve. And maybe you could be some paresthesics. I didn't have any patient
doing a deep incision. So Jorge, one more thing. You know, you talked about the superficial removal of that mucosa. Now I want to know, imagine sometimes the patient does not have even a smile. So sometimes when a patient smiles, one part of the lip goes upper, the upper part stays more, you know, coronal or apical, I can say. You know, some patients does not have harmonic smile. So in those patients, do you also recommend lip repositioning with different kind of cuts, or you find this approach risky in those kind of smiles?
Yeah, it's risky. I solved one case with this, but I have to put not cut different, but have to put more internal sutures at this level to compensate the smile. Also, a point is that we have to put anesthetic at the same quantity of anesthetic. So I use four anesthetics, and at the level of between molar and second premolar, and then between the central and lateral incisor.
And how was your experience regarding the recurrence of the gummy show after lip repositioning?
Well, that's the reason why I removed the double of the mucosa that the patient exposed. So because the recidue of this treatment is very, very high. So when we remove the double, I have very good results, really, but with PDO sutures. When I don't use PDO sutures, internal PDO sutures, because I remove the sutures, the external sutures, that there are single interrupted sutures at day 30 days after surgery. and the internal sutures never remove.
So
Uh,
your internal sutures are like horizontal mattress sutures?
yes,
Yeah.
horizontal mattress sutures. I never remove this, and
yeah.
yes, and I thinking that the low rate of resorption of polydioxanone it helps the results, the outcome.
I think that was one of the.
But we have to evaluate these patients after 2-3 years.
Yeah.
So not only 6 months, not only 12 months.
Yeah, agree with you. Agree with you. And one more thing that I wanted to ask you also that maybe is some of our audience's questions is regarding doing the aesthetic crown lengthening and when we want to have those internal liver or perpendicular incisions. In some cases, I noticed also you kept the tip of the papilla after your incisions, but in some cases it was all removed. You know, in the time of healing, sometimes we see a ledge between our flap and the remaining tip of the papilla. Sometimes during time it heals and it becomes completely even, but sometimes we have a little ledge, invagination of the tissue between our flap line and the tip of the
like this one.
Yeah, exactly. What's your suggestion? I mean, first of all, do you think is it any concern for these type of things? Or my second thing is that do you think is there any way to minimize the appearance of such things because it can happen in different severities?
Yes, we have 2 points here. If we remove all the papilla, we can create a black triangle.
Yeah.
And if we left a little portion of the papilla, we can create a scar.
Yeah.
Yes.
Exactly.
So I think that I prefer leave this because it will disappear. It will be disappear with time.
With time.
Exactly. With time. I'm talking about 6 months.
Yeah.
But it will disappear. I prefer that create a black triangle that I cannot resolve there.
Great point. And one last thing, because you know your topic is really interesting, as I said at the beginning, and I'm pretty sure so many people are interested because it's one of the most demanded procedures that patients may ask the periodontist to solve. But the last thing that I want to ask you is that sometimes after doing the aesthetic crown lengthening, when the patient come back, even after 30 days, you see that the margin of the tissue is more red comparing to other part of the gingiva. You know, not all the time everything looks pink like this, but sometimes you see the margins are more reddish. So what do you think about the reason of that kind of red appearance for after, I mean, after 30 days, after 40 days? It gets better, but why in some cases we see that the margins looks more red and in some cases not?
Yes, when I have this kind of patients, for example, I remember seeing a patient 2 weeks before and we perform a crown lengthening because we thinking that she had a invasion of supracrestal distance. We performed the surgery, but the gingival is still red. And when we take an hemogram profile, we surprised that she have another conditions like an fungal infection. So we treated when I saw this gingival margin red after 30 days. I tried to give some antibiotics or maybe treated it with chlorhexidine gel for 2 weeks, or maybe prove some antifungal for this redness.
Yeah.
Because you treat or if you perform the crown lengthening properly and giving the the distance properly, you could not have this. Another thing that could be happening, another thing is when we perform a flapless crop lengthening, and we can create an infrabony defect because we don't select the case properly. If I'm talking about if you have a case with altered passive eruption where these patients have a thick phenotype, you cannot perform crop lengthening flapless. You have to open this.
Yeah.
And this is another factor to have to consider.
Yeah, great point, because sometimes, it's something that sometimes happens in the practitioner should be ready for some solutions, because sometimes patient asks that everything, doctor, looks good, but why it's red? So we need to have something to offer to the patient, and one at least to show them that
Yes.
it's normal, is it not, can we solve it, can we not solve it? And I have to say again, you presented beautifully, and I truly enjoyed spending this time with you. I have to really say that thank you so much for your passion. Thank you so much for your efforts. And I have to say I'm a great fan of you. Keep it up. Thumbs up, my friend, and appreciate your time again. Really looking forward to see you soon in person. And thank you again for sharing your time.
Thanks a lot. Thanks for having me. Thanks for my English also. Is it's the first conference that I try to make it in English, but we have to learn. We have to improve ourselves.
Yeah, exactly. And I have to say, soon I will have you in my country, my friend. Soon.
Thanks a lot.
Soon. You're more than
welcome. Thanks a lot.
Thank you.
Thanks a lot, Omid.
Thank you so much. Take care. Stay safe.
Stay safe.